Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, everyone. I'm Fatima Cardozo. I'm a senior consultant of medical oncology expert in breast cancer and president of the Advanced Breast Cancer Global Alliance. Welcome to this program entitled One Team, One Goal, the key to better patient outcomes in early breast cancer management. So in the first chapter of our program, we will be looking how to best treat a patient with hormonal receptor positive, HER2 negative early breast cancer. So let's discuss a little bit this case. So we have a female patient, 28-year-old, premenopausal, with no relevant personal history, no comorbidities, no relevant family history except a grand aunt with the breast cancer after the age of 60. She felt a right breast nodule, and the breast imaging exams revealed a 40 millimeter lesion in the right breast with one suspicious axillary lymph node. The biopsy showed invasive carcinoma, non-special type, grade 2, ER 90, PR 60%, HER2 negative, 2 plus by immunohistochemistry, and ISH negative, and a KI 67 of 30%. The lymph node biopsy confirmed the existence of nodal metastasis. The rest of the staging was negative for distant metastasis. So currently we have a CT2, CN1, M0, hormonal receptor positive, HER2 negative, early breast cancer. So the discussion at the tumor board would be, what type of options do we have for this patient? We could either go for upfront surgery, a genomic test to help us discuss or decide if chemotherapy is necessary, ask a genomic test, and use a preoperative endocrine therapy, such as the ADAPT trial approach, or go to neoadjuvant chemotherapy upfront, considering that we have everything we need to take that decision, or start with neoadjuvant endocrine therapy. So my personal opinion would be to ask for a genomic test, or ask for a genomic test and start preoperative endocrine therapy. Without access to a genomic test, I would probably go to chemotherapy up front. Neoadjuvant endocrine therapy is not recommended to be done for a premenopausal women. We have data, good data for postmenopausal, but not for premenopausal. And I always believe that it's much better for the patient to decide if we are going to go for chemotherapy or not before going to surgery, because if we decide to go for chemotherapy, it's better to give it neoadjuvantly, reduce the tumor size, and facilitate the surgery. So what about the role of a genomic test in premenopausal women? There is still controversy on how to interpret the results of the existing trials. So we have the TAILORx trial, the MINDAC trial, and the R-Responder trial. All of them included post and premenopausal women, but much lower number of premenopausal women. And in fact, they all showed very similar results. And I'm going to focus today on the results for the premenopausal women, where you could see a difference of more or less 5% between those who received chemotherapy and those who did not receive chemotherapy, in case they were considered clinically high risk according to the MINDAC criteria, but had a low genomic profile, either a low mama print or a low or intermediate genomic risk score. And this difference is something we discuss very openly today, because the majority of us believes that this benefit, let's call it benefit, that we see of chemotherapy is most likely, and the majority of this benefit is most likely related to the ovarian function suppression induced by chemotherapy in these women. It's also important to emphasize that the percentage of patients who receive ovarian function suppression in these three trials was very low. For the postmenopausal women, just a note saying that if you have a high clinical risk but a low genomic profile, you can safely avoid chemotherapy. So this next slide that helps us to understand how we can implement clinically the results of the MIND-ACT trial. So and this is of course my opinion, if you have a clinical low risk tumor, there is no need to perform a genomic test and no need to give chemotherapy. And the benefit of doing a genomic test is not there, and we can save resources by not doing it. Now let's say that we have a clinical high risk tumor. In a postmenopausal patient, if we do the mama print and it's a low risk, you can safely avoid chemotherapy. And if it's a high risk, there is an indication for chemotherapy. In a premenopausal woman, if you have a clinical high risk tumor with mama print high risk, chemotherapy is indicated. With mama print low risk, you can discuss with the patient to go for chemotherapy or ovarian function suppression and endocrine therapy. Now, there are plenty of ways that we can optimize the use of genomic signatures. All of them are better when used concomitantly with our traditional clinical pathological criteria. We can also use them concomitantly with the preoperative endocrine therapy, a short course of preoperative endocrine therapy. We can optimize cutoffs or use with other signatures. For the sake of time, I'm only going to focus on the ADAPT like schema. That's the use of a genomic test plus a short treatment with preoperative endocrine therapy. So on the ADAPT trial, this genomic test was Oncotype, and what the investigators were done was use both the genomic score and the response to 1 month of endocrine therapy, and decide upon giving endocrine therapy alone or chemotherapy followed by endocrine therapy. There is a second trial that is called the ADAPT cycle, where the randomization is between endocrine therapy and a CDK4/6 inhibitor versus the chemotherapy followed by standard endocrine therapy. What is important to know is when you give this 1 month of preoperative endocrine therapy, you obtain a higher proportion of response if you use ovarian function suppression and an AI. It doesn't mean that afterwards you need to give this in the adjuvant setting. What is even more important is that with the use of these two tools, the genomic test and the response to endocrine therapy, the investigators were, especially for premenopausal women, they were able to differentiate the tumors that had the response to endocrine therapy and were treated with endocrine therapy had a 5-year distant disease-free survival of 97%. Those who did not have a response to endocrine therapy were treated with chemotherapy, and that same result at 5 years was 92. So we have both a prognostic effect, but also helps us with the predictive value on the decision. And this prognostic effect was even more pronounced the younger the woman was. So coming back to our case, the genetic test came negative and the mama print came high risk. So the decision from the tumor board was to provide neoadjuvant chemotherapy with a regimen of dose-dense EC followed by dose-dense paclitaxel. And fertility preservation was discussed with the patient, her and her husband. So the patient received this regimen of chemotherapy with very good tolerance. She was then submitted to breast conserving surgery and targeted axillary dissection within a clinical trial. At surgery, we had still residual invasive carcinoma, non-special type of 25 millimeters, grade 2, and one positive node in a total of 10 removed. And Ki-67 was repeated with 8%, but you know that there's always a decrease when you use chemotherapy. So pathological stage was epsilon P T2, epsilon P N1 with negative genetic test and mama print high risk. So what are the options for the adjuvant part of the treatment? Should we give additional adjuvant chemotherapy? No strong data for this type of tumors, ER positive, HER2 negative. So the focus is now on optimizing endocrine therapy. And should we go for tamoxifen alone, tamoxifen with ovarian function suppression, exemestane with ovarian function suppression, or one of these options plus a CDK4/6 inhibitor. So my personal option would be to discuss between tamoxifen ovarian function suppression and CDK4/6 inhibitor, or exemestane ovarian function suppression and CDK4/6 inhibitor. So the data you need to know about the importance of ovarian function suppression for premenopausal women comes from the text and soft trials, very important trials that have now very long-term follow-up. We have the latest we have is 12 years follow-up, and this year we will have the 15 years follow-up results. And you can see that there is a substantial benefit, and the higher the risk of the the clinical situation, the higher the benefit of ovarian function suppression. To summarize the results in terms of distant recurrence and death, you have a 1.4% benefit for distant recurrence, 2.3% benefit for death at 12 years if you use tamoxifen and ovarian function suppression, and this increases to, in the recurrences, to 3% and 2.6 in mortality, almost the same mortality if you use exemestane ovarian function suppression. We also have data from the Oxford overview, the EBC-CTG overview about the role of ovarian function suppression. And we saw that in breast cancer mortality, for women who remain premenopausal after receiving chemotherapy, you have a gain at 20 years of almost 11%. So no new treatment provides this important benefit. The tool I use in my clinical practice to discuss with the patient if we should go for ovarian function suppression with tamoxifen or with an AI is the compositive risk score that you can find freely available online, and you can enter the characteristics of your patient. Last point, just about the role of CDK4/6 inhibitors as adjuvant treatment. So we now have uh, a longer term result for the use of abemaciclib in high-risk patients, with a benefit that has been increasing with longer follow-up and has a delta now of 7.6% in invasive disease-free survival. So a 32% reduction, relative reduction of risk, and an absolute benefit of 7.6 at 5 years. Most important side effect with abemaciclib is diarrhea that needs proper management, and usually after the second cycle becomes resolved if properly managed. And of course, the reduction in neutrophils that has to be followed. We also now have results for a second CDK4/6 inhibitor, which is ribociclib. Still short of follow-up, but at 44 months, we have a delta of almost 5%. So the question that remains is, can we substitute chemotherapy with the CDK4/6 inhibitor plus endocrine therapy? And this will come to us with the long-term results of the ADAPT cycle. Early results were presented recently, but just for the neoadjuvant part. So finally, for our patients, we decided to treat her with exemestane, ovarian suppression, and adjuvant abemaciclib. So thank you very much for listening to this chapter, and please continue to listen the next chapter that will provide insights on treating HER2 positive early breast cancer.
Hello, I'm Nadia Harbeck. I'm the director of the Breast Center at the Department of Obstetrics and Gynecology at the LMU University Hospital in Munich, Germany. Welcome to the second chapter of this program dealing with HER2 positive early breast cancer. I brought you a patient case, 55-year-old lady with a clinically node negative breast cancer on the right-hand side. Patient is an architect, works freelance, is married, has no children, and has been postmenopausal for the last 2 years. She has no family history of breast cancer, and upon biopsy, we found then a hormone receptor positive HER2 3 plus G3 tumor with a Ki67 of 60%, estrogen receptor was 80%, progesterone receptor 30%. Clinically, on ultrasound mammography, the tumor was 2.5 centimeters, so a CT2 CN0. So the first decision point in the multidisciplinary tumor board would be, do we take this patient to neoadjuvant chemo antibody therapy, or do we do primary surgery? If we look at the ESMO guidelines, we see that for the small tumors up to 2 centimeters node negative, the guidelines recommend primary surgery. And then if the patient stays PT1, PN0, 12 weeks of paclitaxel and trastuzumab for a year, the so-called APT or Tulane regimen. And if the tumor turns out to be larger or um, nodes are found in about 10% of the cases, we underestimate the nodal status, and clinically we will have positive nodes, then we would take the patient to a polychemotherapy together with antibodies, and in node positive disease, dual HER2 blockade. So if we look at the APT trial data, we have seen the 10-year follow-up, and the outcome is excellent. But we have to realize that most of these tumors have been up to 2 centimeters. For the tumor size that we measured in our patient, 2.5 centimeters, we only have about 10% of these patients that would actually qualify here. So I would recommend for this patient to go down the neoadjuvant route, because the data is really small for her disease in the APT trial. And just as a reminder, we just saw at ESMO Breast the outcome data after 11 years of the Affinity trial with a small but significant overall survival improvement, mostly in the node positive or in the hormone receptor positive setting. So if we take a patient to primary surgery and we find out that actually the tumor is larger or has positive lymph nodes, then we can still treat them very effectively with dual HER2 blockade and chemotherapy. So coming back to our patient, our multidisciplinary tumor board decided to go for neoadjuvant chemotherapy. Our standard is 6 cycles of docetaxel, carboplatin, and trastuzumab and pertuzumab. And the patient tolerated the chemotherapy just fine. And then she had breast conservation surgery together with a sentinel lymph node removal. And we found non-PCR. The tumor shrank, but still was 1.7 centimeters, was indeed node negative. And we routinely do our immunohistochemistry in the non-PCR specimen. The tumor was, again, hormone receptor positive and HER2 positive with 2 plus and FISH positive. So the second decision in the multidisciplinary tumor board is, what about the post-neoadjuvant therapy? And if we look at the ESMO guidelines in tumors for 2 centimeters or larger or node positive, we find exactly this chemo recommendation, 6 to 8 cycles of polychemotherapy together with dual HER2 blockade, and then a PCR-based further regimen where upon PCR, we just continue with the antibodies, trastuzumab in the node negative and trastuzumab, pertuzumab in the node positive setting. And if there is residual invasive disease, TDM1 up to 14 cycles is recommended. The reason we recommend TDM1 is because of the overall survival benefit, about 5% at 7 years, as shown in the Catherine trial. And obviously, we we would also give TDM1 if the HER2 status in the non-PCR specimen is negative, or obviously in our case it was positive. It lost a little bit in the staining, but the fish was still positive. But even if the non-PCR specimen is negative, we know from the Catherine trial that patients derive benefit from post-neoadjuvant TDM1, mostly because probably these circulating tumor cells that we're actually trying to treat with the adjuvant therapy, the non-PCR specimen may not be reflective of their HER2 status. So the last question in our patient obviously is, do we recommend also neratinib? We know from the Extenet trial, which was done in patients who had just seen trastuzumab as an antibody, that in non-PCR patients, the additional 1 year of neratinib after the trastuzumab therapy improved IDFS with a delta of about 7% and even overall survival with a delta of about 9%. But this is very exploratory analysis in a small subset of patients that were treated in the neoadjuvant setting in the Extenet trial. We do have more contemporary data from a trial in the German-speaking countries called Eleanor, where we gave neratinib at the indicated indication in Europe, which is in hormone receptor positive, HER2 positive disease, within the first year after stopping trastuzumab. And we saw that we had actually, after contemporary anti-HER2 therapy, excellent outcome for the first 3 years with a disease-free survival rate at 1 year of about 97%. We also saw better tolerability than in the Extenet trial with a dose escalation over the first month, starting at 120 milligram of neratinib up to 240 milligrams of neratinib, and then loperamide prophylaxis. So neratinib would be an evidence-based option in this patient as well. So in summary, after the non-PCR, after surgery, we recommended TDM1, recommended, of course, endocrine therapy with an AI, then neratinib, and we always recommend bone mineral density measurement and adjuvant bisphosphonate. The duration of the AI would be 5 to 7 years, given that this is node negative situation, but actually with a high risk component. So I think this is the standard of what we're doing today with HER2 positive early breast cancer. But obviously, we will have changes in our algorithms over this year, because we're expecting data from the Destiny Breast 05, where TDXD is being randomized against TDM1. Hopefully, we'll see the data later this year. And we also expect data from Destiny Breast 11, where TDXD was used in the neoadjuvant setting, either by itself or as part of a multi-agent therapy regimen, TDXD for 4 cycles, then followed by paclitaxel plus dual HER2 blockade, versus the control arm, which was standard of care, dose dense AC, followed by paclitaxel and dual HER2 blockade. We already know from a press release that this study has reached its primary endpoint, and TDXD led to a statistically significant improvement in PCR. But this is so far the only thing we know, and we have to wait for the data later this year. And then we also expect data from the WSG ADAPT HER2-4 trial, which is a slightly lower risk collective than Destiny Breast 11, mostly stage 1 and early stage 2, where we evaluated TDXD either 12 or 18 weeks versus standard of care chemotherapy with dual HER2 blockade in the neoadjuvant setting, and then a standard of care in the adjuvant setting. And those patients coming from standard of care in the neoadjuvant setting with a non-PCR, we also allowed TDXD as a post-neoadjuvant therapy. So very exciting data, hopefully reported out this year or at the latest next year. So I think our case nicely illustrates how important this multidisciplinary discussion is, as our patient would have fit the APT trial criteria, but actually, since in some of the cases, we may underestimate the lymph node status, and the tumor was slightly larger than the majority of the patients in the APT trial. We actually recommended to take the patient to neoadjuvant chemotherapy and then surgery. Then we had a discussion again about the non-PCR treatment. Multidisciplinary decision making is key in the HER2 positive setting, together with the surgeons, medical oncologists, gynecologists here in Germany, as well as radiotherapists, pathologists, radiologists, and all the other specialties that are integrated into treatment of our patient. And obviously, we shouldn't forget radiotherapy, which our patient also received during the adjuvant phase of the treatment. So with that, I would just like to thank you for your attention, and please continue on to listen to the next chapter, which will provide insights for patients with triple negative early breast cancer. Thank you very much.
Hi, I'm Shani Paluch Shimon. I'm the Director of Breast Oncology at the Hadassah University Hospital in Jerusalem, Israel. Welcome to our third chapter of our program, where we will be discussing triple negative breast cancer. And we're going to start off by discussing and walking through a case. This is a patient of mine, a 36-year-old woman who's married with 7 children. She comes from an Ashkenazi Jewish background, and there was a family history of a paternal grandmother who had a cancer in her 50s, but no further details were available. At the time of diagnosis, the patient was 36 weeks and 5 days pregnant, and she had palpated a mass in her breast and axilla. She had sought medical attention earlier in the pregnancy, but it was told that it was all pregnancy related. An ultrasound was performed, revealing a 3-centimeter mass in her right breast that was medial and large axillary lymph nodes. A right breast core needle biopsy was performed, revealing an invasive duct carcinoma, grade 3, ER, PR, HER2, all negative, HER2 0, with a Ki67 of 80%. Right axillary core needle biopsy revealed carcinoma, and both the breast lesion and the lymph node were clipped. She was referred to our obstetrics department and delivered a healthy baby, and then she was able to complete a PET-CT and MRI of her breast. As can be seen in the images of the PET-CT, we can see a large lesion in the breast with high FDG pathological uptake, both in the breast and in bulky lymph nodes in the axilla. The patient then received guideline-based therapy. This is supported by both NCCN and ESMO guidelines. So she received neoadjuvant chemotherapy with immunotherapy. She received a protocol like in the Keynote 522 study. So she received 12 weeks of paclitaxel, carboplatinum, and pembrolizumab, followed by doxorubicin, cyclophosphamide, and pembrolizumab. And she had a good clinical response, and the treatment was well tolerated. During this time, we also arranged genetic testing for her, and it was discovered that she harbored a BRCA1 test. She then proceeded to have a right lumpectomy and a sentinel lymph node biopsy. There was a residual focus of invasive duct carcinoma over a 2-centimeter area with some evidence of mild treatment-related changes, and she had 1 out of 3 involved lymph nodes at surgery. Repeat immunohistochemistry revealed ER, PR, HER2 still negative. So in summary, this is a YPT1N1. She then proceeded to receive adjuvant radiotherapy and completed 1 year of pembrolizumab. And due to the positive BRCA testing and the residual disease, we also gave her 1 year of olaparib. It's important to comment that we don't have data about giving pembrolizumab and olaparib, but we do have safety data about these combinations from the advanced breast cancer setting. So when we think about the BRCA testing in this case, so this patient would meet criteria for guideline-based testing. She was young, so she was under 40. She came from an Ashkenazi Jewish ethnic background, so she came from an ethnic background where it's known that there are found mutations. In her case, 1 in 40 Ashkenazi Jewish patients with breast cancer, Ashkenazi Jewish patients harbor a BRCA1 or BRCA2 mutation. She had a triple negative breast cancer. She's meeting multiple criteria. And I'm personally of the opinion that all of our patients who could potentially be eligible for a PARP inhibitor, or for whom we think that any genetic testing could possibly impact their therapeutic management, I personally am of the opinion that these patients should be receiving BRCA testing, but she also meets many guideline criteria for having that done. And there's also a family history of a female in the family with a cancer of unknown origin, where there was missing details at a relatively young age. When we think about our choice of neoadjuvant chemotherapy, our data was based, or our choices are based, on the Keynote 522, which really establishes our standard of care and our guideline choices. The Keynote 522 compared standard chemotherapy based on paclitaxel, carboplatinum, followed by an anthracycline and cyclophosphamide with or without pembrolizumab. And in this study, we saw both an improvement in pathological complete response, but also an improvement in event-free survival with a hazard ratio of 0.65. So the 5-year follow-up, we had an event-free survival of 81% amongst those that received the pembrolizumab, and an event-free survival of only 72% in the arm that did not receive pembrolizumab. We also now have overall survival data, which is great news for us as clinicians because this is good news for our patients. And at the 5-year rate, we can see that the overall survival amongst those receiving chemotherapy with pembrolizumab was 86.6%, and it was only 81.7% amongst those who received the chemotherapy only arm. This is a hazard ratio of 0.66, so this is a 34% risk reduction for these patients in their overall survival, which is really impressive. We can't discuss a new agent in our care, especially in the early setting, without considering safety issues. So when we think about safety with the Keynote 522, we have the known side effects that we expect from chemotherapy, so nausea, alopecia, hematological toxicity, and fatigue. There's also some diarrhea seen. But also we need to think about side effects that could also be associated with the immunotherapy. And in terms of grade 3 to 5 adverse events, there were higher adverse events in the pembrolizumab arm. But the more problematic side effects included endocrinological toxicities, the most common being thyroid dysfunction. But we also need to watch out for hypoadrenalism and hyperpituitarism. We also incorporated the use of olaparib for this patient, and we also have updated results from the Olympia from the last 6 months. So the Olympia study evaluated giving olaparib to patients who were high risk in terms of their disease. They could have either triple negative or hormone receptor positive breast cancer and harbor a germline BRCA1 or BRCA2 mutation. If the patients had either significant residual disease or residual disease following neoadjuvant therapy or high-risk features with nodal involvement in the adjuvant setting, they were eligible to be randomized to either olaparib or placebo for 1 year following their adjuvant or neoadjuvant care. And what we see here is the 6-year invasive disease-free survival outcomes, and we can see a 9.4% benefit favoring the arm that received olaparib, with an invasive disease-free survival rate of nearly 80% for those receiving olaparib compared to 70% for those in the placebo-controlled arm. We also have overall survival data, and this data was updated at San Antonio this year. And we can see the 6-year overall survival rate of 87.5% favoring the olaparib arm compared to 83.2% in the control arm. So this is a 4.4% overall survival benefit. This is definitely significant. In terms of safety, we have very good long-term safety results. If there had originally been early concerns about the potential for AML or leukemia or MDS, this has not been seen more in the olaparib arm, and there are no new safety signals when it comes to olaparib. The most common side effects are nausea, fatigue, and anemia, and they're seen most commonly in the first few months, and then they usually taper off. I just want to reiterate that we don't have any data combining olaparib and pembrolizumab in the post-neoadjuvant setting for residual disease, but we do have safety data of this combination from the metastatic setting. Another interesting study that was presented at San Antonio was the ZEST trial. And the ZEST trial was trying to look at if detecting minimal residual disease through circulating tumor DNA could help guide any further intervention and therapy. And the original plan in this study was that patients who were BRCA positive or HRD positive, if they had any residual tumor burden detected through ctDNA testing, they would be randomized to receive niraparib, which is a PARP inhibitor. And unfortunately, the study had many challenges and difficulties along the way, both in recruitment but also in the detection rate. And what they found also that amongst the patients for whom there was minimal residual disease detected, most of those patients who then had systemic workup, so either CT or PET-CT, there was already metastatic disease. So the intervention was already too late. And what we can see here is that there was a small signal that those who did manage to get the niraparib, which was a very small group of patients, there did seem to be a signal that there was a benefit here until in delaying their recurrence. This is really just hypothesis generating because the numbers, as you can see, are very small. But this is an interesting space to watch. We don't yet know how to integrate minimal residual disease into the clinic and how to intervene. But I think this is something we'll hopefully learn more about as we move forward. There are many ongoing trials in the triple-negative breast cancer setting, many of them looking at incorporating antibody drug conjugates. So this is also an interesting space to watch, looking at giving an antibody drug conjugate for patients with residual disease. And there are also studies looking at what to do with patients who don't have residual disease. Do these patients need to continue with the immunotherapy if they've had a complete response? So one of the important things I want to wrap up with is the importance of multidisciplinary care for our patients. And it's really the backbone of how we care for our patients. So in our clinical practice, all new diagnoses will be presented in a multidisciplinary meeting. We have a weekly meeting presenting all new cases. And there we have a medical oncologist, radiation oncologist, breast surgeons, breast imaging specialists, pathologists, nurses, and our psychosocial team. We want to make sure that we're not missing out on any patients who need to get neoadjuvant care. And the multidisciplinary team is critical to make sure that we get our patients on the right path and the right treatment journey. So it's important to make sure that patients who are going to benefit from neoadjuvant therapy are getting the neoadjuvant therapy. And the best way to ensure that is through multidisciplinary team care and weekly meetings. So with that, I'd like to wrap up. Thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation, and we look forward to seeing you next time.
This program was presented by Medscape Education Global.